I went ahead and started the recording, so you can start anytime you want, whenever someone shows up.
Okay, I'll probably start at 7.
Okay.
We'll get started at 7. And we've got a few minutes left here to wait. Okay, at 7 o'clock, we'll go ahead and get started. Today, we're going to be talking about hematological disorders from chapter 27. And I sent out the PowerPoint today to you all. It has a lot of short YouTube videos that I've chosen for you to kind of help you understand the conditions and disorders a little bit better. So you've got lots of little mini lectures inside of your PowerPoint. So I think they're good. I spent a lot of time looking for them for you. So if you're like me, you'd rather watch movies, just read stuff online. So that's, they're all there to help you. We'll go ahead and get started. Okay, the first one is a YouTube site for erythrocytes. And I wanted to pick out a few critical points in your book, too, about erythrocytes. That erythropoietin is what is produced by the kidneys, the glomerulus, to regulate RBC production. So just a hint there, if you don't have your kidneys functioning very well, you can expect that red blood cells won't be made. And remember that red blood cells live 120 days. So it is a long time before you realize that you've got a problem with red blood cells, because they do have a fairly long half-life. To form red blood cells, it's important to remember that you need iron, vitamin B12, folic acid, amino acids, and other nutrients. That it takes a lot of things together to make red blood cells. The youngest red blood cells are reticulocytes. So reticulocytes, an increase in that would tell you that your body's making red blood cells. So if you gave iron, which is needed for, remember, the production of red blood cells, then you would look at the reticulocyte count to see if you had some response from the iron. When you're first born, the hemoglobin that you have is hemoglobin F, which is fetal hemoglobin. But when you get to be older, hemoglobin F only represents about 2% of the hemoglobin in the adult person. The rest of it is hemoglobin A. And so in other conditions we'll talk about in a minute, you'll see where hemoglobin S persists, and it should cause problems for sickle cell anemia patients. Here's a YouTube for disorders of the erythrocytes, and we're going to be talking shortly about the disorders. The most that causes the most mortality is the thalassemia, the beta globulin thalassemia, where children are born with what's called hydrops fetalis. And when you were in your OB course, you may have heard about that. Okay, and then this gives you some other conditions. This little YouTube video. Leukocytes are white blood cells, and the number of leukocytes in your body, when they're first being formed, you're going to look for bands, metamyelocytes, and myelocytes. And if you see a lot or an increase in those, then this is referred to as a shift to the left, and this is what clues people in on that there's inflammatory responses going on. So you hear a lot of people talk about a shift to the left. It just means that you're seeing an increased production of leukocytes, and those are in the band forms, the metamyelocytes or the myelocytes. So you're going to see that when they're describing the differentials. You're going to see that on your record. Disorders of the white blood cells, certainly we're going to be talking about cancers, which you see any disorder of elevation, but not really all that effective in fighting infection. And then manipulating a couple of things here, so have to bear with me just a minute. One, my little machine needs to work right. There we go. Okay, so here's some YouTube disorders of white blood cells. And then platelets, of course, are what help your blood clots. And there are a whole coagulation factors that work like in sequence all the way down the line to make sure that your blood is clotting. One of the most famous of those is factor 8, which is caused hemophilia. So all of these are to kind of help you get back on board with your anatomy and physiology that you had. So they're short and they're good, so I hope that you all will watch them. This talks about the whole blood system. Okay, so we'll move to case number 1, case study number 1, which is Cinderella. Cinderella is a 2-year-old that lives with her stepmother and 2 stepsisters. She gets to eat only what is left from her 2 stepsisters when they are finished, and mostly tanks up on milk, which seems to keep her feeling full. She is pale and tired all the time, probably from all the work that she has to do. She is irritable because she is treated poorly and is often found eating ice and paper. The medical doctor that comes to the house, this is like upgraded Cinderella, to check on the children finds that Cinderella needs further testing due to her poor condition. Once in the hospital, they find that she has hypochromic microcytic red blood cells, low serum iron, and low ferritin. Her hemoglobin was below 11.1. However, her total iron binding capacity is elevated. She has tachycardia and a murmur. What does she have? Think about that just for a minute. She has iron deficiency anemia. How did you know? Well, one thing, her red blood cells didn't have any color either. They were hypochromic and small, and the serum iron was low, as was the ferritin. Her hemoglobin was below 11.1, which qualifies for iron deficiency anemia, but her total iron binding capacity is elevated, meaning that there's protein to bind there, but there's nothing to bind it with. And when you aren't getting enough red blood cells in your body, then you don't have the hemoglobin that you need to carry the oxygen. So your heart beats faster, pumps more blood through places where normally there's not that large quantity of blood going through, and they have a murmur. So when to check for iron deficiency anemia is at 1 year for sure, and 2 years, I think, by law is required. And then if you're have a teenage girl as a patient, they can sometimes lose blood from their menstrual cycles. Little babies that stay on the bottle but don't eat cereal also have trouble with iron deficiency anemia. And people that have trouble with absorption disorders, malabsorption, especially in the duodenum, because that's where the majority of iron is absorbed. So any kind of inflammatory bowel disease would be a problem. If people are being given a lot of aspirins or NSAIDs, that also depletes the iron stores. The most cost-effective lab test would be your complete blood count to do in a clinic, but you could also do ferritin level, because it tells you about body stores of iron, but you cannot do a ferritin level if the child is sick, because any kind of inflammatory condition will elevate the ferritin as well. You can also, do an RDW, which is one of the first things that helps to determine that the child has iron deficiency. Red blood cell distribution width is what that long-term word for it is, but it's one of the first signs of iron deficiency. So when you see iron deficiency anemia, you should also determine the lead levels, because they sometimes will go hand in hand. So if the blood lead level is below 10 micrograms per DL, then it is a concern that might be causing the anemia as well. So when people are checking for hemoglobin in the hematocrit, if they squeeze the finger, then they put a lot of fluid in there, which can produce results. So watch for that, as you may not be getting the level that you need, the accurate level, if they're squeezing the finger to get the blood from there. So remember that if they do have lead poisoning, level above 10, then the chelating medications that they use for lead toxicity can also pull out the iron, so they're going to need iron supplements. So when you see lead problems or anemia, iron problems, think that those two can go in cahoots with each other. So if there's no response to iron therapy within a month, then you may want to do more lab work, like peripheral blood smears. Or even levels by venous puncture rather than just finger sticks. It is recommended that the baby, if they're exclusively breastfed, that they start receiving elemental iron supplementation at 4 months of age, because remember how long the red blood cells last. So they might be disappearing by the 4th month of age, and continuing those along until they get adequate amounts of iron-containing foods like cereals. You shouldn't give them babies, that is, whole cow's milk under a year of age due to its low iron content, and goat milk does not contain iron nor folic acid. So that's not really a good solo diet for the child. And then starting at 1 month of age for preterm infants, start them on iron, because remember they didn't stay around long enough with their mother to get really good iron stores. Tell parents whenever they're giving iron not to give it with meals or milk, but to give it with vitamin C juice, because that helps the absorption. And not to be too worried if their stools turn black. It honestly means that they're getting the amount of iron that they need for their body. And then a lot of people are worried about the teeth staining, but it will go away when you clean their teeth. Let me see. I think that was what I wanted to tell you about that. So here's about treating iron deficiency anemia. We talked a little bit about it. Cinderella received iron supplementation at 3 to 6 milligrams per kilogram a day by mouth. Her stepmother was told to give it with some form of vitamin C and to watch for GI symptoms, which when you take iron, you could be constipated, you could have diarrhea. The stepmother was to bring her back in 4 weeks for a recheck of her hemoglobin. So in about a month, you should actually be able to tell that the child has been on iron. She was to continue the iron until the hemoglobin was normal, and then to recheck after normalization in 6 months. So once you get it to the level that you want it to be, then you ask them to come back in 6 months. The health department was coming to check Cinderella's room for something. What would that have been? So what do you think they're wanting to check Cinderella's room for?
Lead paint.
Absolutely, absolutely. That's what they're coming to check for, is to see if, you know, she lives in an old place, probably in a dump where they put her, and she may have had lead paint. And there is a site talking about lead poisoning, because we really didn't have a lot on the PowerPoint slides, but there's about lead poisoning. Case number 2, Anastasia. Was a surprise to her parents who have had numerous miscarriages prior to her birth. She is 2 months old, but is pale and sometimes too tired to nurse. She wears out so quickly that her Eastern European parents decided to bring her to the doctor. She has failure to thrive. After lab work, it was discovered that she has hypochromic microcytic anemia of 6, and she has hepatosplenomegaly and mild jaundice. What does she have, and what might the treatment be for her? She has a very common condition that we're seeing more of these days than usual because of the influx of people, from all over the world into the United States. So, what is that?
Spherocytosis?
No, it's thalassemia. And there's a little, right down here, a little YouTube video about it. It's thalassemia major. And she will receive multiple red blood cell transfusions. And then because of that, she'll have to have iron chelation therapy to treat her high iron state. So when you give a lot of red blood cells, then you're getting a lot of iron into your body. That's a heavy metal. So she will have to have that chelated out to prevent iron toxicity, really. This is a hereditary condition, and we are seeing more of it now because of the influx of the populations that have this in their genes. Okay, case study number 3. Jenny is a daughter of a hippie mom and dad who are both strict vegetarians. Jessica is their daughter. I think I've changed children's names. Jenny is their daughter, and she presents today with inadequate weight gain, chronic diarrhea, and irritability, according to her parents. Upon exam, she is found to have followed a vegetarian diet like her parents. She is anemic, according to her lab work, but does not have a tapeworm. So if she would have had a tapeworm, what in her blood would have been elevated? This is found in allergy and also with parasites. An elevation of what?
Eosinophils?
Absolutely. Her tongue is beefy red, smooth, and her mouth and tongue have sores. Her white blood cells and platelets are normal. She has large hypersegmented neutrophils, macrophotocytes with anecytosis and poikicytosis. She is weak and pale. What does she have, and what causes it? Okay, what are her red blood cells? What are her neutrophils? Large, hypersegmented. She has megaloblastic anemia, is what this child has, and usually it's due to lack of folic acid and vitamin B12, and that would be her hippie parents have done that to her with a vegetarian diet. So she needs folic acid anywhere from 1 to 5 milligrams a day for up to 4 months. And then her maintenance vitamins after that with folate in them. She needs vitamin B12 sub-Q or IM 1 milligram weekly for 4 weeks and then monthly thereafter. So she has megaloblastic anemia. Okay, case number 4. Sam is an African-American boy who has been seen from time to time for a crisis event. This usually occurs whenever he gets dehydrated, like from a gastroenteritis illness. He is often tired, has pain in his joints, swelling and inflammation of his hands and feet, priapism, and abdominal pain. He is 5 years old, but he has had these problems since he was about 6 months of age. What do you think he has?
Sickle cell?
He has sickle cell anemia. And there's a little video that helps explain it a little bit better. But remember we talked about earlier that hemoglobin A was the adult hemoglobin, and that you only have like 2% hemoglobin F. There's other hemoglobins too, there's C and a bunch of other ones. But the one in sickle cell anemia is hemoglobin F. And what happens to the red blood cell, because this is an autosomal recessive disorder, which means it takes 2 carriers, and if they had those 2 carriers, the sickle cell trait, had 4 children. One of them would have the disease, 2 of them would be carriers, and 1 wouldn't have anything. So there's a 25% chance of having a child with sickle cell disease. Well, what's interesting is in the African countries, if you have the trait or you have the disease, you're immune to malaria. So the only people that get it are the 25% that don't have the trait or don't have the disease. So all the people that don't have it are killed off from malaria. No, they're not killed off, but they're made really sick. And then the people that are able to transmit the disease on further down the line, they don't get the malaria. So it's kind of a natural immunity to malaria. I think your book talks a little bit about that. But anyway, anytime there's reduced oxygen tension in the body with these children with sickle cell anemia, their cells, remember that the red blood cell doesn't have a nucleus. It doesn't, because it can swish in and out of all kinds of places successfully. But what happens to these red blood cells when there's reduced oxygen tension? They form a spherical shape. And so wherever they go, they're not going to flow as smoothly through the vessels as they would if they were circular and squishy. So they tend to clump up. And what you see is clumping up in the joints of the fingers. So their knuckles are big, and then their little fingers go down looks like a spindle shape. And that causes a lot of pain. So just think anywhere in the body, those cells could clump up. So you could have strokes, you could have heart attacks, you could have thrombus in different places. If they're clumping up in the spleen, over time, then that destroys the spleen, and so they're really prone to infections like pneumococcal organisms. So the last thing you want, if you're thinking if you have spherical shaped red blood cells, the last thing you want is a dehydration situation, because if the vascular department is shrunk, then those spherical cells have more of a chance of clumping up and causing pain and causing destruction. And that's what happens to these children, and that's why even sometimes they have to have strong medications, pain meds, to help them get over their situation with all of their thrombus or joint destruction. So you really want to encourage hydration with these children. You want to give them a pneumococcal vaccine because their spleens may be destroyed after a lot of time of clumping up. And the bacterial infection is sometimes the leading cause of their death. So these are children. The trait is very unusual. People with the trait, it's very unusual for them to get into any major trouble, like children that have the disease. One of the faculty was discussing a patient that was 20 years old that she saw, an African-American woman, and she had that joint destruction or swelling in her fingers, and she had 102-degree temperature, so she had never been diagnosed with sickle cell, but certainly given just those few symptoms, that would be something that would be in the forefront of the brain. They used to screen for this whenever any African-American child came into the hospital. No matter what they came in with, they got screened for sickle cell anemia, but that's not done anymore because it wasn't kosher to do that. Case number 5. Fabiola is an Italian-born little boy who was wound up in the hospital for a red blood cell transfusion. His primary care provider placed him on a sulfa medicine for his urinary tract infection, and he ended up with pallor, jaundice, lethargy, headache, and red urine. The doctor said that his body was destroying his red blood cells. What does he have? Think what he might have. It's not very common, so it would be something that would be rolling off of your
Is it
tongue.
ITP?
The glucose S phosphate dehydrogenase deficiency. And there are at least 2 sites there for you to learn a little bit more about this condition. Two really good sites to watch. Have some mini lectures in the lectures. Case number 6, Susie had a viral illness a week ago, and now she has bruising over her legs and a recent nosebleed. Whenever she brushes her teeth, her gums bleed. Her doctor ordered some lab tests, and they showed a low platelet count below 150,000 with an otherwise normal CBC. Her PT and PTT were also normal. What does she have?
Is it von Willebrand factor?
No, because
No? Okay.
it's her platelet count that's the clue there. She's not missing clotting factors. She's missing platelets.
Is it ITP?
It is ITP. That's right. Okay, so it is ITP, which is idiopathic, which you really believe that, most people believe that this viral illness she had caused an autoimmune reaction, and so she's destroying her platelets. Okay, knowing that, let me read you something and you tell me what this is, okay? If the PTT and the PT are elevated, in this case, they're normal. You see that? But what if they were elevated and the platelets were also diminished? Then you would be seeing a syndrome that's secondary to things like sepsis, toxins. You see this syndrome a lot in the intensive care unit, where the systemic coagulation process is activated, which results in a depletion of the platelets and coagulation factors, which leads to bleeding. What is that?
DIC?
Pardon? Somebody said it.
Is it DIC?
Yes, disseminated vascular coagulation, right. The difference between ITP and DIC is that the PT and PTT, in this case, on the screen, are normal, but in DIC, they're elevated. That's the difference. Again, another video for you. King Koenig is concerned about marrying, this is case number 7. King Koenig is concerned about marrying his wife because she is a cousin of his, and he has trouble with excessive bruising, hemarthrosis, and prolonged PTT. There's your answer. What does he have?
Hemophilia.
He has hemophilia, that's right. And there's a video there for you. Looks like it's not underlined, but you'll have to go in there and underline it to get it to click and work. This is case study number 10. Jonathan is an 18-year-old who has a cervical lymph node enlargement, which is painless. The node feels rubbery and firm and non-tender to palpation. He has had fever, decreased appetite, and weight loss. He also complains of drenching night sweats. What would you begin to think about him having?
Lymphoma?
He has, right, Hodgkin's lymphoma. That's right, and there's a whole section there on the YouTube for you about that particular problem. Let's see. Not sure about my numbering here, but whatever. Looks like I've kind of lost count for some reason. Okay, I see what's happened. Okay, this is not case number 8, but never mind. Trina is 3 years old and has had a history of repeated infections, weight loss, repeated nosebleeds, and enlarged lymph nodes. Trina is pale, irritable, and chronically tired. The mother is concerned about what is wrong with her. What do you think is the problem?
Leukemia.
So with leukemia, usually the child, like this child, has had repeated infections and fever and weight loss, bleeding from some area of the body, usually the nose. The lymphs and the spleen would both be enlarged, and she could have joint pain and headache, vomiting, or lethargy, and that would be leukemia. You're right. and there's the site to go to hear more about that. Case number 9. Stephen is a 15-year-old who comes to the clinic with abdominal pain, distension, fullness, constipation, and non-tender his lymph enlargement. He has had this problem for almost a month. What do you think his diagnosis is? And we talked about him already, didn't we? Non-Hodgkin's lymphoma. Okay, I think that's the last slide. I want to encourage you to watch the short videos because they are helpful to kind of put it all together and teach you a little bit more about each particular condition. I think they're very helpful. They'll be helpful to you. You do have the study guide for the next exam. It'll be very similar to what you've already had 2 of. So is there any question about the study guide? This material will not be on that test. It'll be on your final exam, and I will be sending you out a study guide for your final exam as well, and it probably will be a little more detailed than what you have been getting with regard to prior material. Your study guide for recent stuff, which will be this week and next week on behavioral health disorders, will be pretty much listing the topics. But on prior stuff, it'll be detailed because I know it's been a little while since we've talked about that. How many questions on the final 50, just like there are on all the tests? No more than 50. And like I said, you'll get the name, the topics from the last 2 weeks, and then you'll get more detailed study guide from if I'm asking anything about before this particular lecture and next week's. Certainly more of the final will be these last 2 weeks. So if I'm asking anything before then, you'll know a little more specifically what that is. So you don't have to worry a lot about prior stuff for the moment anyway. Any other questions? Because we have, I think, 1 more session, and then it's time to study for the final. So next week I will be talking about behavioral health issues in children. This is an added section. We haven't had this before, so it'll be new, new stuff for the PEDS course because we feel like you're going to be exposed to a lot of little children that have behavioral health needs, and you need at least some jump on what to do for them. So it's an added unit. It hadn't been there before, but I think it's important. Just as important as the physical stuff is the mental stuff. So I'm looking forward to teaching that since I'm adding it this year, so that's kind of exciting for me. Any questions about anything you can think of? Do look at the YouTubes. They help you remember the stuff. Okay? Anything for the good of the order? Danielle, Missy, Carissa? Is there somebody else on this line? I can't see them. Jennifer, Christina?
As far as the discussions go, we're pretty much done with those?
We are,
Okay.
Yeah.
I want to make sure that I'm not missing anything.
No, we got done with them at the first, and that was, I guess in some ways that was good, but it would have been nice to have strung them out over the semester. But no, you're done with them. If you've done whatever you're supposed to do number-wise, you're done. You don't have to worry about those anymore. Just focus on, you know, the next test and the final, and then you guys are on to something else from there.
So, Dr. Mars, on that same topic, 'cause I know that a lot of the people did like their 5 discussions for that initial conversation, but I was not one, so I think I've only done 3 or 4. So can I just go back to previous weeks and comment, or how do you want me to make sure I get my 5?
Well, it might be good if I did another discussion and just, you know, entitled that for people that still need some. So maybe for, what week would that be? This is Monday. So maybe I can come up with something tomorrow that's controversial for people to discuss that haven't had an opportunity to. I thought originally we had everybody, but if we don't, then you need another opportunity. I'll be happy to provide that for you.
Okay, sounds good.
Okay. Rather than go back, we've kind of done all that other stuff. So
Okay.
I'll see what I can find tomorrow. I have more time. Mondays are always my meeting days, so they keep me pretty tied up on Mondays. I don't get a lot done on Mondays, but Tuesday's a different story. I can get to on Tuesday. Anything else, you guys? You have questions? Please ask. That's why I'm here tonight, is to be synchronous, to be right here with you if you need it. Hearing none? I hope you all just think Thanksgiving's right around the corner. We can all get stuffed like the turkey. Well, y'all have a good night then. If I don't hear anything
All righty,
else.
thank you.
Email or
Thank
call
you.
me if you need me. Okay?
Thanks.
Thank you, guys.
Thank you. Good night.
You're welcome.
I'll stop the recording.
Thank you, Ronnie.